Why your sciatica might not be sciatica. It may be sacroiliac joint dysfunction and how to tell the difference. In my clinic, I see a revolving door of patients who have spent months, sometimes years, stretching an irritated nerve because they thought it was a tight hamstring. They arrive frustrated because their sciatica isn't responding to traditional treatments. The reality is that lower back, pelvic, and leg pain often present as a confusing, debilitating symptoms. While a patient may have both and the sensations may overlap, the recovery paths for SI dysfunction and true lumbar sciatica are worlds apart. To stop the cycle of ineffective treatment, you must first identify which side of the diagram your pain lives on. By understanding the mechanics of your symptoms, you can move from guesswork to a targeted protocol that actually works. 1. The one-finger test for SI joint pain. The most significant differentiator of SI joint pain is its pinpoint mechanical nature. Unlike the broad traveling discomfort associated with nerve irritation, SI pain is highly localized. In clinical practice, the first thing I look for is the one-finger sign. I ask patients to point to the exact source of their pain. If they point directly to the posterior superior iliac spine, PSIS, those bony prominences you can feel on the back of your pelvis, or just to the inside of them, it is a hallmark of the SI joint. This pain is almost always unilateral, one-sided, and behaves like a mechanical catch. It is triggered during specific movements, such as stepping, climbing stairs, or shifting weight. When the movement stops, the sharp mechanical irritation usually ceases immediately. It is, quite literally, a biomechanical hinge issue. 2. The electrical reach of sciatica. In contrast to the pinpoint location of the SI joint, true sciatica presents a much broader and more volatile spectrum of sensations. Because it involves the compression or irritation of a nerve, typically in the lumbar spine, the symptoms follow the nerve's path from the lower back through the buttocks, thighs, calves, and even down to the toes. Rather than a mechanical catch, sciatica is defined by its nervy quality. Patients often describe it as deep, mysterious pain. Unlike sacroiliac joint pain, nerve pain is hard to pinpoint. It's there, sometimes severe, but it's hard to point to the exact location. That's because your body is literally composed of trillions of nerves, and there are no two cases of sciatica or other radiating nerve conditions that are the same. Electrical sensations. Sharp, shooting zaps or shocks. Sensory distortions. Pins and needles, tingling, or a total loss of sensation, numbness. Temperature shifts, a localized feeling of intense burning or unnatural deep cold. Reflexive cramping, persistent spasming, particularly in the hamstrings, as the muscle reacts to the irritated nerve signal. 3. Why nerves continue to hurt after they are irritated. One of the most telling ways to distinguish between these two conditions is the duration of irritation. SI joint pain is mechanical. If you remove the stress from the joint, the pain usually subsides. Nerves, however, are highly vascular and chemically sensitive tissues that do not recover instantly. As I often tell my patients, nerves like to hurt for a while. So you can stop making the irritating movement, get out of the car, or even go lay down for a while, and you're still going to be getting those symptoms if it's nerve pain. While a joint behaves like a light switch, a nerve behaves like an echo. Even after you lie down or stop the aggravating activity, the tingling or burning may persist for hours. This stubbornness is due to the chemical inflammation surrounding the nerve, which requires a specific cooling down period rather than just a cessation of movement. This is why ice is always a good therapy for this type of pain. 4. Stabilization versus decompression. Choosing your protocol. Treating the SI joint with sciatica protocols, or vice versa, is a recipe for stagnation. You must choose the strategy that respects the underlying physiology. For SI joint pain, the stabilization strategy. The goal is to eliminate torque, the shearing or twisting forces that act like a wrench on your pelvis. Movement strategy. Prioritize bilateral, symmetrical movements where the pelvis acts as a solid, stable pillar. Recommended exercises? Focus on very gentle wall squats, glute bridges, and gentle pelvic thrusts. These exercises will restore proper movement patterns of the lower back and pelvis while engaging the supporting muscle groups. What to avoid? Asymmetrical movements like lunges, which put uneven torque into the joint and can worsen inflammation. Support. In acute cases, an SI belt can provide the external stabilization needed to allow the ligaments to settle. For sciatica, the calming protocol. The goal is to reduce inflammation and create space, decompression, for the irritated nerve. Movement strategy. Avoid impactful or heavy movements initially. Prioritize blood flow through frequent, low-intensity walking, ideally 3 sessions of 20 minutes daily. Horizontal positioning. You must find a position of preference to take pressure off the nerve. Common successes include side lying, lying on the back with legs propped on a chair, or lying prone on your stomach with a pillow under the lower abdomen. A technique particularly effective for relieving pressure caused by stenosis. 5. Conclusion. Moving toward the right solution. Accurate self-diagnosis is the first step toward a functional recovery. If your pain is a pinpoint mechanical catch that responds to stability, you are likely dealing with the SI joint. If your pain is an electrical echo that travels to your toes and lasts for a while after you remove the initial irritation, your path lies in nerve decompression. As you reassess your symptoms today, ask yourself, is my pain a mechanical light switch that flips on and off with my steps, or is it a fading echo that lingers long after I've found a comfortable position? The answer will tell you exactly which protocol your body is waiting for.